It's not always completely simple to use medications for depression and anxiety. There are, as you can see, there are happy pills, but they're not always quite as successful as we would like. So this is the same disclosure. What I'm going to talk about is reviewing assessment, learn why we don't use benzos, learn how to use antidepressants successfully. So we have searched for a depression cure for a long time. Canst thou not minister to a mind disease, pluck from the memory a rooted sorrow, raise out the root-written troubles of the brain, and with some sweet oblivious antidote cleanse the fraught bosom of that perilous stuff which weighs upon the heart? I just composed that on my way over here. What do you think? Pretty good, huh?
You ought to be a playwright.
Yeah. I mean, who knows? Shakespeare thought of antidepressants way back when, or Macbeth did. And then we've got a picture of Hieronymus Bosch trying to cut the stone out, which is another attempt that we've had to remove the madness from people. So it's perennial hope. And to flash forward, here we are into the 1960s, where this poor older woman has chronic fatigue and mild depression and can't seem to get her potatoes peeled. But Ritalin solves that problem. I would say that Ritalin is a Schedule II stimulant used for ADHD. I wouldn't say that it's standard treatment for depression anymore, although I think there's some use for it in very medically ill elderly. But we have probably shied away from it because in most patients, stimulants don't produce a lasting relief of depression and does have a bad downside of dependence. And any antidepressants certainly don't create happiness or remove all depression, although I do think that they can be useful tools, minimizing the burden of despair and restoring interest in activities and relationships. Although they have sometimes been called mood elevators in popular press, I think of them much more as building a floor under mood rather than raising the ceiling. It's not true that you feel better an hour after a dose like you would with cocaine or amphetamine. But I think people do get less stuck, stay in a very despairing or anhedonic state for less periods of time and less severity than comparative groups not on antidepressants. So I'm going to talk about assessment of chronic pain and depression, about how they occur together, how you sort the two out, and then treatment of depression with chronic pain. So DSM-5 did not change major depression criteria in a major way, other than removing the bereavement exclusion. Before, you couldn't diagnose depression in the presence of bereavement, but it turns out that a death of a loved one, although a major blow, is not unique in stressors or losses associated with depression, and many people who have onset of major depression have significant losses, and the committee just ended up thinking that bereavement was not uniquely problematic. So major depression is depressed mood or loss of pleasure in one's usual favorite activities for a period of 2 weeks nearly every day. So those are the cardinal symptoms, and then there's a list of vegetative symptoms that, to my mind, are a sign that this is a neuroendocrine phenomenon that has some staying power and is less likely to remit on its own. So the prevalence is about 2 to 4% in the general population, more in women than men. And as you move to the inpatient setting, the prevalence doubles. As you move to the inpatient setting, it doubles again. Pain clinics have a lot of depression. It's hard to get any reliable or precise estimate because the referral patterns to different clinics are different, so that they have different rates of depression. But it's high. So when trying to dissect out the relationship over time of pain and depression, I find this study, which is now more than a decade, coming up on 2 decades old, but it's a very thorough, broad-based study. Nearly 5,500 patients from 15 sites in 14 countries were assessed by interview and questionnaires. And they found that about 22% of primary care patients had persistent pain. And that was defined as pain of at least 6 months that either prompted health care seeking or caused disability in their work or major life activity. So that group was 4 times as likely to have an anxiety or depressive disorder compared to people who didn't have that persistent pain. And this was worldwide. So this relationship between pain and anxiety and depression was actually more consistent across cultures than the relationship between chronic pain and inability to work. So they did a follow-up study on a subset of that. About 3,200 patients from the same sites were assessed not only at baseline but also at 12 months. And 50% of the people that had persistent pain at baseline still had that pain at 12 months. And that was predicted best by number of pain sites. So people who had generalized or multifocal chronic pain were more likely to continue having this persistent pain a year later. And we just had a visit from Dan Claw, who is a fibromyalgia expert. And he has been producing research over the past year on what he calls fibromyalgia-ness, or meeting fibromyalgia criteria among other pain populations. And he has actually shown that this widespread pain phenomenon, particularly when it's combined with poor sleep, poor cognition, and low mood, is a robust predictor of bad outcomes from joint replacement, from hysterectomy, and now he's assessing broader post-operative and acute trauma populations. And he's arguing that this fibromyalgia criteria questionnaire is a very good measure of pain centralization. So anyway, there's a good sign here that people with multifocal pain are more likely to have continuing problems. And although they did not show the relationship between this multifocal pain and psych disorders in this study, in other studies it's clearly been shown. So in this sample of 3,200, around 9% had new onset persistent pain, and that was predicted by baseline psychiatric disorder, perceived poor general health, and occupational role disability. So people constantly ask me, does the pain cause the depression or does the depression cause the pain? And the short answer is yes, they both do. The longer answer is this: persistent pain at baseline predicted the onset of psychological disorder with the same strength that a baseline psychological disorder predicted the onset of pain. So basically, depression and pain feed off of each other and make the other one harder to treat, which was what I was alluding to at the start of this. If you add a third term in, which is disability, that helps strengthen the relationship between pain and depression. So, to just give a few examples of the way in which chronic pain reduces response to depression treatment. So there was the ARTIST efficacy trial using SSRI treatment, treated 573 patients. And in that trial, a risk for poor treatment response, and this was a classic SSRI fixed dose efficacy trial. I can't remember which actual SSRI it was. Prozac, Paxil, Zoloft, something like that. And mild pain made people 50% less likely to respond. Moderate pain cut the response rate in half, and the severe pain cut it by a quarter. So it was a very clear inverse relationship between pain severity and response rates. So even to a more flexible, multimodal depression treatment strategy, such as in the impact effectiveness trial, so that combined problem-solving therapy with flexible antidepressant dosing with a nurse care manager, so it was much more comprehensive and flexible. But even in that trial, those people who had no to low pain interference did quite a bit better than those who had high pain interference. It's true the other way around too, that depressed patients respond to many chronic pain treatments less well. It's certainly true, like many of my patients argue, if you reduce my pain, my distress would go down. And that's, of course, the right way to handle it in an acute pain or a procedural pain situation. But treating depression with opioids does not reduce the depression. It is, in fact, associated with increased depression. I should update this slide because we now have evidence from Jeff Schurer's group in St. Louis that probably duration more than dose, but both dose and duration of opioid treatment are associated with increased risk of depression, either new depression in people that never had depression before, or recurrent in people that have had it, or worsening depression in people who've already got it. Why is this? There's suggestive treatment. Research like Ajay Wasan from Brigham and Women's showed that depression was associated with reduced response to acute opioid treatment of discogenic back pain. And we've shown in some of our samples that depressed patients are very ambivalent. They have a kind of a problematic and conflicted relationship about opioids. They think that the opioids are helping them, but they have a strong desire to cut down. They have a very mixed mind about whether opioids are helping them. So what about antidepressant effectiveness? Most antidepressant trials are just one drug against a placebo, lets you know that it's more effective than placebo. There's been a lot of controversy about that too. It's clear that more severe depression is more responsive than mild depression. But one of the few trials that tried to replicate the challenges of clinical antidepressant use is one called the STAR-D trial, which stands for Sequenced Treatment Alternatives to Relieve Depression. It was a huge trial, 2,876 subjects involved. It was an open-label, pragmatic trial of major depressive disorder treatment in primary and specialty care, where there were multiple randomizations, where if the first thing didn't work, then it took you to a second, a third, and a fourth phase to try to get people better. And it was informative, but a bit dispiriting, the results. So you can see in the picture on the right kind of response rates in the bar graphs to any one of the treatments. And then the kind of description of what the treatments were is a little bit more described on the left. So the first treatment that everyone got was citalopram or Celexa, a very well-tolerated, probably the SSRI I used the most. But the sobering part of it is in this group, as in many groups, only about 30% got better. So the people who did not get better with the first treatment were randomized to either get an additional treatment, and they added either bupropion, which is Wellbutrin, or buspirone, which is Buspar, to this to see if they got better. And again, they were able to get about 30% better. And that's sort of the consistent story here through all the different levels of switching and augmentation, is of the non-responders, if you switch, if you add bupropion, you add buspirone, or you switch to bupropion, or you switch to sertraline, switch to venlafaxine, even if you switch to cognitive therapy, you get about 30% more better. At level 3, they went from the SSRIs and the SNRIs to drugs that are a little harder to take, nortriptyline, which we use a lot in the pain setting, but it has definitely a more substantial side effect load, and that only increased response rate about 15%. Mirtazapine brought it up by about 20. And then there were more augmentations that I do sometimes, although they're not really primary care level things, to add lithium to antidepressants or triiodothyronine. And then at level 4, they went to what are considered really the heavy-hitting options. Tranylcypromine is an old MAOI, brand name Parnate, or they tried the combination of venlafaxine and mirtazapine, which has been called California rocket fuel by some people. But it's a potent combination, but it also picked up just a few percent additional. So what's the bottom line, the take-home message from the STAR-D trial? Only a minority of depressed patients achieve remission with first-line treatment. That's everybody. That's not even talking about pain patients. And no specific treatment really won all the prizes. Each helped a different subset. But people who did achieve remission were less likely to relapse in those who had some improvement or a response but not remission. So it does pay to work hard to get the symptom level down. So when I am talking to patients, and mostly patients in our pain clinic, about antidepressants, I never see people that haven't already been exposed to them. Everybody's seen an antidepressant, and they often have strong negative opinions. Same as about physical therapy. Everyone's failed antidepressants in physical therapy. So I don't oversell them, because they certainly are imperfect medications, as you saw in the STAR-D data, with side effects. And I tend to see people with multiple layers of comorbidity. PTSD, histories of trauma, past substance abuse, if not current substance abuse, concurrent anxiety disorders, a lot of things going on that makes antidepressant responsiveness more complicated. And for patients who are ambivalent about antidepressants, specifically like a record of not tolerating multiple drugs, I tend to become less rather than more assertive. I try to give people choices. I lay out a number of options describing what the non-antidepressant options are, what the antidepressant options are. I will be quite firm about the fact that benzos are not a good alternative to the antidepressants. As we talk here, and David Taubman has mentioned, that norepinephrine reuptake inhibition drugs are clearly better analgesics for neuropathic pain. There are some trials suggesting that they are better for musculoskeletal pain. You know, there's a fair bit of SNRI data in fibromyalgia, at least with respect to Cymbalta and perhaps Savella. Another good point is that antidepressants that block the 5-HT2 receptor are often associated with better sleep and anxiety improvement. So which drugs do that? The tricyclics, trazodone, nefazodone, mirtazapine do that. And they're better tolerated, particularly by the patients who have concurrent anxiety disorders like PTSD or panic. In the perennial debate about whether the pain or depression comes first, and the corollary that, of course, by treating depression, we're assuming that their chronic pain is all in their head, I really don't argue with patients about, oh, well, I wouldn't have been depressed if I didn't have pain, that's fine. I don't see any reason to argue with that, although if you dissect out the time of the whole thing, it's often not that clear-cut. But you don't want to accept the conclusion that they often draw, which is that if you treat my pain, and by that they usually mean with opioids, that the depression will go away. So there's multiple layers of refutation for that. Opioids do have transient anxiety reducing and mood elevating effects, but there's really no good data that suggests it has sustained antidepressant effectiveness. As much as we hoped to the contrary, there's not randomized but good prospective cohort studies showing that opioid treatment retards return to work, does not promote it. And then I mentioned this new group of research that I've gotten involved with showing that actually opioid treatment increases the likelihood of developing depression in the presence of chronic pain. On the other hand, you should emphasize that depression treatment makes other pain treatments work better. So, I've certainly heard many patients say, antidepressants made me worse. It does happen. It can make people angry. It can make them suicidal. It can make them more agitated. It can make them more depressed. It needs to be explored. It can mean that the clinician was ignoring my pain or ignoring me and writing me a prescription to get out of the room. It can mean that the antidepressant made them have more negative affect of other kinds. And those are complicated patients. I think that often the right thing to do is to refer them to a psychiatrist to help sort out all of that. It could be a pharmacologic issue. It could be a comorbidity issue. So we, in a tertiary care pain setting, tend to see depression with chronic pain complicated by a bunch of other things. Substance abuse, anxiety disorders, personality disorders. All that complicates the treatment. And there's no one easy thing to tell you to do in those situations. I do believe that people who do have PTSD, the same way as you have to often treat the depression before you can treat the pain, I often think you have to treat the PTSD before you can get to the depression, before you can get to the pain. So it's yet another step that you have to take really before you're going to make a substantial pain reduction. The trauma needs to be recognized and addressed before the depression treatment can succeed. And unfortunately, a lot of our patients have layers of trauma. It was not only the car wreck 5 years ago, but it was the abusive husband 10 years ago and the evil stepfather 30 years ago. All that is relevant and needs to be addressed. The other issue is that depression can really function as either an acute or a chronic illness. And recovery from acute illness like pneumonia or a fracture is more straightforward, both physiologically and psychologically, because recovery basically just means returning to your former health, your former identity, and your former life. After a week or a month off of work, boom, you're back. Things are as they were before, no big challenge to your life and your identity. But chronic illness recovery is not returning to yourself, but reinventing yourself. So you get diagnosed with diabetes, you have to change who you are and your lifestyle, and you can't just go back to who you were before you got diagnosed with diabetes. And that's really the same in many chronic pain situations, is that it's more a process of reinventing yourself than bouncing back. And that's very true with the depression. Many patients I see can't remember a time when they weren't depressed. And that means it's kind of disorienting to them to get out of that depressed state. So the question is, if depression is that awful, what keeps it going? How does somebody end up chronically depressed? And you have to think about what strange, obscure advantage chronic depression has. And the best way I have to describe this is that once you're on the floor, you can't fall down. Meaning that depression protects you from further disappointment. If you don't let your hopes get up, you can't be disappointed again. If you don't try new social initiatives, you won't get rejected. If you don't apply for a job, you're not going to miss out on the job. And these are called, in the depression therapy literature, avoidance behaviors, where people stop trying stuff because they don't want to go through the disappointment of not getting it. And that is a very difficult pattern to change. Because when the patient starts making these initiatives, it's going to feel to them like they're asking for trouble. That, I ask them for a date, they're just going to say no. If I go and apply to a job, all they're going to say is that I've been out of work too long, I'm too stupid, I can't do the job. And it is true that they are likely to experience disappointment if they try more things, but it's also true they might succeed. And they won't if they don't get out of the house and try. So I think it's really important, as you fold depression treatment into pain treatment, to be very clear about the goals of treatment, that the goal is resumption of life, not cessation of pain. We can't make it all go away, and that partial victories with depression or pain are still victories. But we have to realize that, the pain world has people like Frank Falco in it who are promising people they can make it all go away. So we do have to make clear why that we think that way is not available to our patients, if it isn't. No.
Oh,
That's
okay.
the end.